All right, we have our first panel of the program, The New Old Age. More than 10,000 people turn 65 every day in the United States. As Americans are living longer and healthier lives, increasing life expectancies are also being met with declining birth rates. What are the social and economic consequences of an aging population? And how should the country's changing demographics inform policies and programs? Joining us in this discussion today are Ramsey Alwin, President and CEO of the National Council on Aging, Lindsey Miltenberger, Chief Advocacy Officer with the Society for Women's Health Research, and Melissa Batchelor from the George Washington University School of Nursing, Center for Aging, Health, and Humanities. She is also the host of the podcast, This is Getting Old. Welcome.
Let's go down the line and do kind of brief introductions, both on your organization and your kind of passion for this specific issue. And we'll start with you. Right.
Wonderful. Well, Bob, thanks for having us. At the National Council on Aging, for over 70 years, we've focused on improving the health and economic security of older adults. Through service delivery, helping older adults find jobs, gain access to programs that can help with food and medicine, navigate their chronic conditions, prevent falls, and gain access to life-saving vaccines. All that service delivery work we do with the tens of thousands of community-based organizations out there, that feeds our advocacy efforts. Yes. Oh. Can you hear me now?
Yeah.
At NCOA, we're deeply passionate about the issue of aging well. As a matter of fact, we believe aging well should be a right and not a privilege based upon your skin color, your gender, or even your zip code, like the Congresswoman raised earlier.
Lindsey?
And I'm with the Society for Women's Health Research, or SWHR. SWHR is a more than 30-year-old national nonprofit, and it was founded by a group of women who saw these areas of need and opportunity in the women's health space. They noticed that there was a lack of OBGYNs at the NIH. They noticed that women weren't being included in clinical trials. And they noticed that women's health and women's reproductive health was kind of an afterthought. And so they came together. They were integral in the passage of the 1993 Revitalization Act, which stood up the Office of Research on Women's Health and Statute. But it also required the inclusion of women and minorities in clinical research. Today, our mission is about promoting research on biological sex differences in disease and improving women's health through science, policy, and education. So we're really working to make sure that we're thinking about women in terms of a lifespan approach, and healthy aging is a key part of that. So often we think of women just in terms of what we call bikini medicine. It's about reproductive health, but it's so much more than that. And especially right now where we're seeing that women are sick and getting sicker, it's so important that we focus on improving health throughout the lifespan.
Melissa?
So Melissa Batchelor, Associate Professor in the School of Nursing at George Washington University. So I'm a nurse practitioner, and I've always worked in long-term care with older adults. At the Center for Aging, we've been doing a lot of work the past 4 to 5 years with 6 different age-friendly cities in Maryland, DC, and Virginia. We put on an annual event called the Age-Friendly Ecosystem Summit. And it's really about bringing people together to talk about the solutions that we're going to need to care for an aging population. And so through that, started a weekly podcast called This is Getting Old, moving towards an age-friendly world. And while I do talk about aging, ageism, age-friendly initiatives, it's really about all of these things that aren't in place for this population. And that's really what's getting old.
Speaking of your podcast, what have you learned from it, whether it's feedback or from actual real people?
Well, the content that actually gets the most traction is my work around Alzheimer's disease and helping family caregivers. And again, I think that there are so many different resources that people kind of get lost in trying to find and access information. And actually, when you go to YouTube and you type in Alzheimer's disease, a lot of the content that used to come up were kind of boring academic, like lecture PowerPoints. And so I think just having somebody having a conversation with them is really what they appreciate. And so it's kind of taking the science and the evidence-based work that we do and translating it for the public so that it's consumable to them. And they're looking on YouTube to find information. My demographic is 65 and older, mostly female. But YouTube is a search engine just like Google. And so most of the podcasts are titled around a question that people have. But it is a way to interact with people and let them ask questions and then give them an answer.
Because the internet's a great tool, but sometimes it can be overwhelming,
Right.
especially for older people. I mean, my dad would not know how to get on YouTube. So does that focus them? Because you don't learn a lot of this caregiving in school.
Right. For like the regular person, I was like, we learned a lot
For
about
anybody,
caregiving. I had like a lot of years of training for caregiving. But yes, the public doesn't. And, the AARP has done a lot of work, around and the challenges that they are facing. They're being asked to do a lot of medical care. And most of the care that's happening now, even with Alzheimer's disease, is happening in the community. And so while there's a big focus on acute care, it's really home and community-based services is where this care is going to take place. And partnering with, and letting people know what an area agency on aging is. What is the National Council on Aging? Yes. Right. And so it's educating them to say there are resources. I think a lot of caregivers feel like they're isolated and they don't know what to do. So they are turning to the internet. And if they have somebody who's like, hey, here are federal resources. Here are resources in your state. And here's, what's what an age-friendly city looks like. Do you live in one? Mm-hmm. So it's just kind of sharing solutions.
Ramsey, you want to?
Oh, absolutely. I mean, it's overwhelming navigating all the complexities of aging. It's increasingly complicated as it relates to our health. It's increasingly costly. Older adults themselves can be overwhelmed. Caregivers can be overwhelmed, but you're not alone. Right. There are over 600 area agencies on aging. There are over 10,000 senior centers that we work with directly that are deeply rooted in communities that can help individuals navigate these chronic conditions. And chronic conditions are what are top of mind for us.
Sure.
Our research demonstrates 80% of older adults experience 2 or more chronic conditions. We've done some novel research using a new methodology with the University of Massachusetts Boston's Gerontology Institute, really looking at the true cost of those chronic conditions, the lost wages, the medical costs, the non-medical costs, and it's incredible. I mean, diabetes, hypertension, cancer, those are your most costly chronic conditions. And what you'll find is women and people of color experience those conditions disproportionately and, of course, have fewer resources to draw upon in order to afford them. Mm-hmm. And I'd love to just share a couple numbers because they're eye-popping. So for whites, cancer tops the list of chronic conditions as most costly. $252 billion a year in lost wages, medical costs, and non-medical treatment costs. For blacks, it's diabetes and hypertension, and they come up at about $35 billion a year, respectively, in out-of-pocket costs and lost wages. And for Hispanics and Latinos, diabetes is the most costly, and our research demonstrates that's about $40 billion a year. And so we really need to look closely at the full range of interventions that can help individuals navigate those chronic conditions. And that's brought us on a journey, and I'd love to share more about that later.
Lindsey, you talked about disparity between women's research and men's research and landmark laws. I believe that you mentioned one in the 1990s, 93. Where are we on that? How does women's research compare to men's research now, and how far has it come, and what are the obstacles moving forward?
We've made a lot of strides in improving the representation of women in clinical trials, but we still have a long way to go. We particularly are seeing now, while more women are participating in clinical research than ever before, there are still efforts that need to be made to improve the representation of diverse populations of women in clinical trials. So racial and ethnic, different racial and ethnic groups, people in, rural versus urban areas, and importantly, the inclusion of pregnant and lactating populations in research and what that means. And then the other thing I'll flag is that there are really key areas where research has shown that women are still underrepresented in clinical trials, things like cardiovascular disease and mental health, and that's really unacceptable. So we've made progress, but we still have a long way to go.
Melissa, what concerns you the most? I mean, 10,000 people turn 65 every day in the United States. We have healthcare worker shortages now. Mm-hmm. The healthcare system is still trying to deal with COVID and supply drug shortages. But moving forward with an aging population, what's your biggest concern?
I think, the workforce is certainly an issue. We have about 1 million physicians in this country, less than 6,500 are geriatricians. Out of 4 million nurses, like less than 2% are board certified in gerontology. So we have a workforce largely unprepared to care for older adults. And so the Age-Friendly Health Systems Initiative has helped, try to move to geriatricize health systems instead of trying to create individual providers. I think the biggest thing is, like when we talk about aging right now, most people think, we're talking about the boomers, and that's where that 10,000 a day, number comes from. But actually about 3 years ago, the millennials took over as the largest generation. So the boomers aren't the largest generation, and the millennials started turning 40 a couple of years ago, which makes them old enough to sue for age discrimination in the workplace. So my mission is we have 25 years to get ready for the millennials for the things that older adults of today need. And so it needs to be a conversation about us. It's, we are all aging. I've always taught gerontology to nursing students, and I've never really had one run in the classroom and be like, I want to work with older adults. I want to work in a nursing home. They don't, but it's like, if you work in an emergency room, if you work in mother baby, by default, you are a geriatric nurse because there'll be a grandmother that wants to come in to hold that baby. You're going to have to know how to interact with that person. 60% of our hospital beds are filled with older adults. So I think it needs to be a conversation about us and not about them, because we're all aging. And one of my jokes is that I would take care of someone who's like 80 years old, and they'd be like, well, I eat in this dining room because the old people eat in that dining room. I'm like, well, how old are they? I mean, older adults are anybody 10 to 15 years older than ourselves.
Right.
So it really is about all of us, because we're all aging, and it's actually ageism is the only ism that's kind of absent from the national conversation about DEI. But it's the only inclusive one too. It's the only one that we're all doing. But our thoughts about aging actually predict our health. So if we have self-imposed ageist beliefs, we actually have poor health outcomes because of it. So what we think about aging actually matters a lot.
Right, and with aging, as you mentioned, everyone is aging, and it's come up obviously in a political sense. It mentioned in the debate last night about age of politicians, and when an athlete is struggling, the media will call him aging or her aging. But if they're doing well, they're not aging. So, and then David Axelrod said, age only goes in one direction, unless you're a Benjamin Button. Lindsey, what about the stigma of aging? Has that improved? We've seen, I think, the stigma of mental health during COVID improve, not fully, but certainly more people tackling it. And now as people get older, and that did take a bit of a blow during COVID because the population average age expectancy went down. But where do you think we are with that?
I think stigma is improving, but again, there's work to be done. I think that's going to be probably a common theme here. I think even whenever we talk about things like menopause, I've been really heartened to see, people come on both sides of the aisle increasingly talking about menopause in recent weeks and recent months. But there's definitely still a stigma when it comes to talking about menopause in the workplace. The society is currently analyzing some results from a survey that we just put into the field, trying to learn from people about the workplace experience when it comes to menopause. And, as part of that, we're learning that people are kind of uncomfortable talking to employers about menopause. Similarly, employers don't know how to talk to their employees about menopause. So how can we kind of encourage things like, workplace policies within organizations to make those conversations easier? I think the more that we take steps like that, the more that we can break down stigma, and the greater we can advance this conversation.
Ramsey, you've made the case, which is the sound one, of course, but I want you to talk about a little bit more that financial health equals physical health. If you don't have the financial health,
That's right.
It's tough to get the physical health.
Absolutely. I mean, we see it every day with the millions of older adults that raise their hand for help and come to the National Council on Aging or the vast number of community-based organizations we're working with. Your health can determine your wealth, and your wealth can determine your health in the United States of America. And in our deep commitment to ensure aging well is a right and not a privilege, we're really trying to unpackage that and look at some of those drivers, some of those social determinants that end up having implications for our life expectancy, ultimately. The disparities are significant in the United States. And while some enjoy the gift of additional years, we've still not yet cracked the nut on the quality of those years. And so that's why we commissioned this research around the cost of chronic conditions, because they are such a driver. And in going on this journey, in addition to doing the research, we got out there into communities. We held town halls across the country at senior centers, in states, in communities, and really heard from people directly about their challenges. And the reality is when Social Security is not enough and they're making tough decisions between medication and foods and exercise, that comes into play in terms of their health outcomes. We literally heard folks sharing with us their struggles around navigating hypertension and diabetes and the chronic conditions that exacerbate all the rest, obesity, and their frustration of not feeling seen and not having access to the full range of interventions related to obesity. And so that was an issue that bubbled up to the top for us. We literally heard people saying they felt invisible when talking with their doctors about various interventions, that they live sick and then die. They live sick and they live in extraordinary circumstances, struggling, and don't feel seen and heard, and ultimately die if they don't get the right supports. That brought us to a bubbling point, to a tipping point, if you will. And we realized we need an obesity bill of rights. And so that's something we'll launch in January with the National Consumer League together to really get out there and talk about the importance of evidence-based health prevention, evidence-based health promotion and disease prevention interventions, and the full range of interventions related to obesity specifically, given the interplay between health and wealth.
How did that idea come about? How long was it kind of percolating?
Well, it was really organic, going out there, hearing from older adults themselves and finding them deeply engaged. You know, you'd think that this was a topic that was particularly sensitive, but it came up organically, talking about chronic conditions and some of the drivers and some of the challenges, especially as individuals were seeing that there are new solutions, pharmacological interventions that can actually help, that private insurance covers, that the VA TRICARE covers, but Medicare beneficiaries can't gain access to. And that felt unjust, that we are missing a piece of the puzzle here.
Lindsey, as far as a magic wand, if you had policymakers or maybe something that's working that should be highlighted, what are the solutions so that we have good quality of life over the next decade or two?
What I would really love to see, and I think that it's something that's feasible, is greater coordination across the federal government about what they're doing in women's health. Okay. So let's bring together the National Institutes of Health, everything under HHS, HRSA, FDA, CMS, but then also bring in the Department of Defense and the VA, who are conducting really, really impactful research, and come together in a coordinated way, have those agencies share their findings, have public meetings so that people can be aware of what they're doing and come up with solutions that way.
Melissa, same question to you.
You said the magic wand.
Yeah, what do you think policymakers should do? Like, what is the most important thing that they should focus on?
I know what I was thinking, because I was thinking a lot while you were talking about women's health, particularly because most women are caregivers. They're the backbone of our, of the care that's being delivered in the home and in our communities. And so I think having and there are some legislative efforts right now in Congress to help caregivers, but just like employee assistance programs, talking about menopause, it's also how do you, care for children and aging parents? So I think there just needs to be more support for caregivers of people living with chronic illness, but also there needs to be a lot more focus on health promotion. Like right now we have a sickness-based healthcare system, and I think nurses, it's a great opportunity for us to really kind of step up and to try to help people to prevent chronic illness. It's not that's not normal aging, although it's common. And so it's changing those perceptions and trying to get people to make lifestyle choices that prevent chronic illness.
Go ahead.
Well, and to that point, expanding Medicare coverage to be able to provide access to evidence-based health promotion and disease prevention programs in non-clinical settings. So many community-based organizations administer programs that we know work, but Medicare doesn't cover it. And they're not in a clinical setting. So we need to close the loop on that.
How, and this is for anybody who knows or has studied it, but what could we learn from other countries internationally? The United States is very focused on the United States, but are there Obviously, everyone has their own health system, but has anyone seen something, well, that's something smart that maybe U.S. policymakers should do?
That's interesting. I mean, I can take it from kind of a menopause angle. So
Right.
we hosted an event recently with a couple of members of the United Kingdom's House of Commons Women and Equalities Committee about their efforts on menopause. In July of 2022, they released a report about menopause in the workplace. And they provided a set of recommendations to their government about things that could be done. They intentionally were not very prescriptive, but they made recommendations. Let's try things like, menopausal leave. Try it with one sector that's predominantly women and see how it works. Hire somebody at the federal level to focus specifically on menopause in the workplace. Come up with a template that workplaces can utilize to help women that are navigating this transition. And so there may be some interesting things for U.S. policymakers to take from reports like that. I think, it's always important to look at other countries and see what they're doing and see how we might be able to learn so we don't have to necessarily reinvent the wheel. But that's one area where we might be able to take some lessons learned.
Melissa, regarding mental health in particular, which does affect older Americans disproportionately, what do you see? How did COVID affect older Americans? I think the audience and people watching all know that a lot of people suffered during COVID. And what was the impact of that on mental health of aging Americans?
Yeah, I think COVID definitely probably shed some light for all Americans about the impact of social isolation and loneliness.
Right.
So with a broader understanding from like a population health perspective, I just hope that people don't forget the impact that social isolation and loneliness can have on the mental health of everyone. And, for our communities to try to pull together, to help one another. Like I lived up here in DC for about eight years, but I moved back home to North Carolina in February of this year. And I was like, everybody here is so nice. Like
in North Carolina,
like
right?
everybody in the elevator up there, like, hey, and I'm like, okay, wow, I had not even realized like how that was it's a different culture here,
Right?
But how do we get people to interact with one another and for communities to kind of come together to help one another? Like the village is another neighbors helping neighbors type model where people support each other, whether it's transportation or getting to the doctor. So I think we just need to focus more about how to pull communities together and pull people out of their homes to interact with one another, particularly intergenerational activities and housing.
Because it's so lethal. I mean, social isolation for older adults, it's like smoking a pack of cigarettes a day. It's that lethal. And with the social distancing required due to the pandemic, I think there's a lot we have to unwind to get people feeling safe and comfortable to come back again. And those relevant community-based organizations can be great vehicles for that. Every day, over 1 million older adults go through the doors or log on to a senior center to engage in programming. And increasingly, those are becoming gathering places for different generations as well. Adult day health, co-locating with daycare facilities. So when the Surgeon General comes out and talks about the lethal nature of social isolation, I think it's really an opportunity for all of us to reflect on intentionality in terms of bringing each other back to connect and how that really is essential for our public health as well.
Lindsey, I want to end on a positive note. What are you positive about, whether it's trends or treatments going forward, where there are a lot of problems we've discussed. COVID obviously set the world back years in many ways. But what's a positive aspect that you've seen progress and hopefully that will continue?
The thing that I am most excited about going into 2024 is last month the White House announced the White House Initiative on Women's Health Research. So this is about prioritizing and elevating women's health at the federal level. It's about understanding where we're funding how we're funding research, where we're funding research, and then where there are gaps and opportunities. So they're going to bring these agencies together, hear from them directly about what's happening right now. They're going to, hopefully listen to stakeholders from the public and private sectors about where there are needs and opportunities. And I hope that the recommendations moving forward will represent a paradigm shift in women's health in this country. So it's not seen as a niche market when women are in fact 51% of the population, and should be seen as such.
Absolutely. We're running out of time. Please thank our panel for joining us this morning. I hand it back to Sarah.